So the addition of Olaratumab to our availability with respect to treatment for patients is very interesting because over the last 5 to 10 years, we've done a number of large clinical trials trying to improve upon survival for patients with soft tissue sarcoma. And unfortunately, we have not been successful until the addition of Olaratumab to doxorubicin became available. And so from a patient standpoint, you certainly want to improve your survival, but you don't want to do it at a cost. And the cost that you don't want it is at the cost of quality of life. And so for a patient standpoint, we did see that there is an increased risk of neutropenia, there is an increased risk of mucositis, there is an increased risk of nausea and vomiting. However, the increased risk is a subtle increased risk for most, or at least that's my perception of it. And the increased risk is not really a grade 3 or 4 increased risk, which to me is what causes decreased quality of life for patients. And so from a patient perspective, most have tolerated it quite well. Most have been able to maintain themselves on it. And really the addition has not really caused many dramatic negative impacts for these patients.
So my experience with Olaratumab in combination with doxorubicin, we've actually treated over 20 patients on different protocols with this combination. There is some increased rate of mucositis and of cytopenias with the combination, but overall it's relatively well tolerated. It's similar, I would say, to single agent doxorubicin in general. More importantly, patients that finish their doxorubicin dosing and continue on Olaratumab have excellent quality of life. They really have almost no side effects from the single agent Olaratumab therapy in continuation. As part of we had a different trial called JGDI, which is a drug-drug interaction trial looking at doxorubicin and Olaratumab and any cardiac effects. And we had over 15 or 16 patients on that trial. And a large proportion of them actually finished their doxorubicin therapy and have been on Olaratumab single agent for over a year without progression. And many of these patients had progressed previously on other chemotherapies. So I think there's definitely some activity here, even in the single agent after they've finished their doxorubicin dosing. So I think it's very exciting. And comparatively, comparing to other combination arms such as AIM or adriamycin ifosfamide, the toxicity profile is dramatically better. And that makes a big difference for patients that have incurable metastatic disease.
Whenever we look at clinical trials in oncology, one really has to look at what endpoints are the most important endpoints. I do feel strongly that when we look at soft tissue sarcomas, that an overall survival endpoint is a very meaningful endpoint and probably the most meaningful endpoint, especially for metastatic disease or unresectable disease. One also has to look at how many patients have been treated. What was the quality of the data, where was the trial done, who was doing the trial. And I do feel very confident that based on the phase 2 and 1B data for Olaratumab with doxorubicin, that it is a superior treatment compared to single agent doxorubicin. And at least in my practice, it is to adopt this as the standard of care. Will this always become the standard of care? It's hard to say. It really depends on what the phase 3 data shows. But if the phase 3 data mimics the phase 2 data, then I would feel very unfortunate that I didn't adopt it sooner. And if the phase 3 data doesn't mimic the phase 2 data and perhaps it's not an overwhelming survival advantage, then I would feel I've done my best. I looked at the data that I had available and it didn't cause much more toxicities, and so I don't feel that patients were at a disadvantage.
Having worked with Olaratumab since about 2010 when the original trial took off. I feel like I've had a lot of in-depth experience with this compound. And what I really like about Olaratumab is its side effect profile. What we found was there was a slight bit of an increase in neutropenia that may have been associated with the fact that people stayed on adriamycin longer on the combination arm. And, there is the real side effect in the Midwest of anaphylactic reactions like we have to any other monoclonal antibody. But outside of that, if you can get to maintenance with this drug, and we had some people that were on maintenance for years, this is well tolerated. And you come, you get it, you go, and you go about your normal life. And it's the highest quality of life I think we really do have, which is the maintenance with a monoclonal antibody. And so having used this and having seen patients respond late on maintenance to therapy, having seen patients respond in combination, I'm really excited about this.
Regarding my confidence in the results of phase 2, I'm very confident in that. The differences were so dramatic. It was not something that I think was an error in any way. So I definitely feel, and my experience with the combination has been really similarly dramatic as well. So yes, I definitely do feel confident in that. I'm extremely hopeful that the phase 3 will confirm that, and I'm waiting on, I'm waiting to hear those results enthusiastically, so we'll see how it goes.